Good afternoon to everyone. I welcome everybody to this another online edition of Jaipur Surgical School. To give you a brief background, so this is an online initiative which has been basically started for general surgery trainees who are abroad, especially in Middle East, Africa, and other countries, so that who cannot attend our morning session and are able to attend this session. So we have lectures every Friday from 3 to 4 p.m. from very eminent faculties across the world, and the schedule is provided in our WhatsApp group. So in this series today, we have an important lecture on safety in surgery by Professor Raj Govind Sharma, surgical oncologist at Mahatma Gandhi Hospital, Jaipur. Unfortunately, due to some commitment, he cannot attend personally, but the recorded video is there. So I will start and share the video.
It is a wonderful initiative. People who do not have the time to attend classes or lectures, and this would be available on YouTube also, that at any time it can be accessed and it can be reviewed. So what we are going to do is we are going to talk about safety in surgery. This is for all the residents, for the faculty, for the senior people, for the OT staff, for almost everybody who has to do something or the other for the theatre. I am Dr. Raj Govind Sharma. I am heading the Department of Surgical Oncology at the Sri Ram Cancer Center at the Mahatma Gandhi Medical College, Jaipur. Supposing God meets you and asks you, ask for a boon, what would you say? What boon would you ask from God as a surgeon? Would you ask for many patients? Would you ask for excellence in surgery? Would you ask for, say, bloodless surgery? Would you ask for being artistic in surgery or having a very good assistant in surgery? What is it? Think about it. Talking about quality and patient safety, is there really a problem? We normally say we cannot make mistakes. We don't make mistakes. Errors and mistakes come far and few between, and they are usually not significant. And then finally we say, it hasn't happened to me, and probably it's never going to happen to me. Have you seen this thing in the hospital or anywhere in the clinic? Probably people who are in very sophisticated corporate hospitals might not have seen this, but in most people in medical colleges and in city hospitals must have seen this, whether it is in the OT, whether it is in the OPD, whether it is in the ward, anywhere. We must have seen the footsteps slipping and the patient having a fall or the table falling or something like this. It is a laughing stock. Even in auditoriums, we've seen that when it becomes dark and people who are coming in late or who are going out in the dark have a fall and people laugh on it. This same thing happens in the theater. And then we say, no, it's not my mistake. There is a lot of confusion. Wrong side, but right surgery, right side, but wrong surgery. And it depends on which side you are standing. You can say it is on the patient's left or on your left side or as you face. So all these things can cause a lot of confusion. So we have seen this left leg, but tumor on the right, and right leg, but the tumor left. And occasionally it is in the papers, and it is so devastating for the surgeon who has had this misfortune that he comes in the papers on the wrong time, at the wrong place. Sometimes our mind gets tricked. Now, quickly say the color, not the word. What is this? Pink? Yellow? No, this is red. Blue? No, this is green. Similarly, it takes time to be able to really catch some things. And that is why at certain times the mind can get tricked. We must have often heard in the newspapers or hushed up conversation in the hospitals that somebody had a missing sponge or an instrument, and somebody is, any surgeon in his career must have seen or removed these, mostly from other people, but must have seen something like this where this sponge has been left behind or there is something missing in the theater. And usually we say, I'm not responsible. It's the nurse's mistake. And then the blame game starts. When we make a mistake, what are the usual things that we say? It just happened. No one told me. Or could it be no one can dare tell me? It must have been done. It is always done. You always check. You always check the number of sponges. It's not my job. Someone else has to do it. I do my job well. I operate it very well. I don't know about others. Why didn't they put the tube? Why didn't they keep this thing? Why didn't they suture it properly? I'm the boss here. I'm not to be bothered about small little things. I do everything perfectly. Others make mistakes. I feel what I do or did was what I felt was right. I have been doing this for years and it has never happened before. Sometimes it happens and then we are into real deep trouble. Why do we need to talk about safety in the hospital? Hospital is a people-intensive place. It provides service to the sick around the clock, 24 hours daily, 365 days a week, days a year. People have a free access to enter any part of the hospital at any time for advice and treatment. The hospital atmosphere is filled with emotions, excitement, life and happiness, death and sorrow. Since hospitals operate under continuous strain, it gives rise to irritation, confrontation, conflicts, and aggression, threatening the life of hospital staff and hospital properties. Every day in the corridors, we see confrontations amongst people in the staff. Whose safety are we talking about? Is it people's safety? Is it the place safety? Or is it the safety of the property? I think all put together, it is the hospital's safety that we need to address. Safety of the place means safety of the infrastructure, prevention of fire, prevention of electrical and mechanical failures, and safety from these failures. Safety of the property, stores, very important. All your heavy equipment, all your intensive equipment is in the stores. Your assets, your laparoscopes, your robots, and other equipment. All this constitutes the safety of property. And then the safety of the people, safety of the patient, foremost, and also the people who come along with the patient, the visitors, the caregivers, and then the safety of the staff. Equally important, everybody. If a patient attendant takes a fall because of slippery floor, it is our responsibility. It is the hospital's responsibility. This happened days ago and was in the newspaper. You must have never heard this, and I hope you never hear about such a thing. But this thing has happened. In the days gone by, when we used to use iodine and spirit, spirit is quite inflammable, and this could have happened. Where else would you have fire in the theater? Has anybody seen a fire in the theater? Yes, we have seen that. While doing proctoscopy and using the cautery, there was a blast because of the methane gas. Yes, there are highly inflammable things in the theater. Even nowadays, we don't use spirit so much, but this hand rub and hand sanitizers are highly inflammable, and you need to keep them away from your cautery machines or other source, electrical source which can catch fire. So fire in the theater has happened, and we need to be very careful about this. Why patient safety in surgery? About 230 million major operations are performed per year worldwide. That means out of 25, 1% has some sort of a surgery or not. There are major complications in 3 to almost 16% of these cases. Death rate from major operations are extending from 0.2 to 10%. That is 7 million disabling complications and 1 million deaths per year. 7 million disabling complications and 1 million deaths per year, half of which are avoidable. Hospital medical errors kill 98,000 Americans each year. This has been reported by an American news investigation agency. Whose error is this? 66% of the times the accidents occur entirely by the patient. 16% accidents due to error by the hospital staff. 14% accidents are staff and patient both being equally responsible. 4% accidents due to physical, mechanical, or electrical errors. These Sentinel events have been reported. There is something known as event reporting, which should be followed by every operation theater. What do we mean by Sentinel event or event reporting is anything which occurs, which is unusual, which can be potentially harmful, even if it is not potentially harmful, but anything which goes missing or which is abnormal, which is different from the routine in the theater, needs to be recorded in an event register. So what are the reported events? Suicide, wrong side surgery, surgical complications, medical errors, delayed treatment, fall, restraint, and others. So we need to be, most of them are not reported. Small little things like leaking cylinder or a cylinder falls down or somebody gets a needle prick or somebody gets a hurt. We normally don't report all these, but it should be reported so that such things do not get repeated. So patient safety means surgeons have small number of errors on a personal level. I just had, if I want to say, if you ask any surgeon personally, he'll say, yes, about 2-3 years back, I had this one single complications. You add up all the number of surgeons who have had such complications once in a lifetime, and that adds up to a huge number. So surgeons themselves have a small number of errors on a personal level, but it adds up to a huge number. Deaths occurring from medical errors, like I said, 98,000, far outnumber deaths from major vehicle accidents, breast cancer, and AIDS. So you see, medical errors. We must have read that book, Complications, which highlighted the importance of surgical checklist and the complications occurring in the operation theater and surgical errors. Death from medical errors, almost about 7,000. And near misses are not counted. Like I said, we normally don't report that this happened, there was a break or something went missing or a cylinder was loose, something like that. This is an everyday happening, but it is not reported. Like patient on the table, the hand has not been tied and it falls down and we realize it quite late. Similarly, the leg goes off the table and throughout the surgery, it has been, or even if we are giving a position and suddenly drops because you are painting, you are scrubbing, it is slippery. And the person who is holding it might, by mistake, slip, and the hand will slip and the leg will fall and cause injury. We need to be very, very careful regarding this. This is an everyday happening, but we don't normally report it. Dangers in the operating room, wires, loose wires everywhere. If that is the situation, probably someday some nurse is going to fall into your hands. But we have to be very, very careful that such electrical wires, such suction tubes, such cautery wires are not on the floor. And that is why in modern theaters you have the pendants. Despite those pendants being there, we normally have some or the other device which we will have to connect to a wall plug. Goals of surgical safety. We need to protect patients from harm. We need to avoid or reduce errors. We need to promote safe operative practices, and we need to protect ourselves and our staff from harm. What are the types of safeties? Environmental safety, medical safety, surgical safety, equipment installation safety, electrical safety, blood safety, sanitation, infection control, and biomedical waste disposal, laboratory safety. All this constitutes patient safety. And even much more than this thing, anything in the hospital related to the patient safety is to be addressed. The surgical setting is one of the most potentially hazardous of clinical environments. You can see the leg going down, or the leaking drip, or a cautery in the fluid, or a leaking bag, or the next case already the equipment has been shifted, a leaking wind, or loud music, or somebody having a cold, or electrical hazards, sharp instruments, and fire hazards, and so this is a wonderful cartoon. I got it from the net, which how dangerous and hazardous the OT environment can be. Quality in patient safety. There are less deaths from adverse events occurring in nuclear reactors and the airline industry, and monitoring processes in place. They utilize checklists, proactive reporting. There is a structure and like plane crashes are very, 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 very rare, but they have to use the checklist, and they have to do a detailed debriefing before. What I've written here is a plane crash. You know, there was a plane crash, and after the investigation, it was found in the black box, which is a recorder which records everything that goes on in the plane. That there was a very senior person, and his image was more than junior assistant enamored by his image. And there was something going wrong. The senior was making a mistake, but the junior could not speak because of his big image and for the fear that he is such a big man, he cannot make a mistake. And because of that, a plane crashed and 300 people had died in that plane crash. We'll come to that how such things.
Supriya madam.
Spot this diagnosis. What is this? We can laugh about it. But yes, in the theater, if it is a 2 hours, 4 hours surgery, the endotracheal tube causing pressure or the Ryle's tube causing pressure. When you put the tube, the bag was empty, but by the end, it has filled up and it's pulling on. For 2 hours, if you have a pressure on the nose, this is what happens. So it could be a lifelong mark for the patient, and you could be sued for it. It's a pressure necrosis by nasogastric or the endotracheal. It can be in the theater also, it can be in the ICU also, because if the patient is on an endotracheal tube for 24 hours, this definitely can occur. We need to prevent this. Most serious potential complications: infection, hemorrhage, wrong patient, surgery, wrong site surgery. There are about 1,500 to 2,500 incidents per year in the USA. 13% of adverse events are wrong site, wrong patient, or wrong procedure, which has been done. Wrong medication, skin breakdown, burns, nerve damage, ischemia, and problems with the eye. Because if the patient has been under anesthesia and the eye remains open, then the patient can have exposure keratitis. Other potential hazards: energy sources, electrical, thermal, laser, radiological, chemical, medications problems, antiseptics, cements, bone cements. You know, when you prepare bone cement, it can cause hypothermia. It becomes very hot and it can cause burns. Intravascular dyes and irrigating solutions can be sometimes causing allergy. What is the difference between error and complication? Error means an adverse event that results in unintended harm to a patient by an act of omission, rather than by disease or the condition of the patient. Whereas surgical complication, any undesirable, unintended, and direct result of the operation affecting the patient, which would not have occurred had the operation gone as well as could reasonably be hoped. So, error is unintended harm to a patient by an act of omission, not because of the disease or condition of the patient. Now, Medicare has stopped reimbursement for reasonably preventable complications. Now, what are the reasonably in the United States? What is reasonably preventable? Foreign objects left in the patient, catheter-associated urinary tract infection, central line-associated bloodstream infections, incompatible blood products, air embolism, patient fall or trauma, mediastinitis after cardiac surgery, pressure ulcers, surgical site infection following bariatric surgery, orthopedic procedures, poor sugar control, DVT, pulmonary embolism following certain orthopedics procedures. Have we seen this? Patient shifting and transfer dangers. While shifting, patient slips and falls. While shifting, tube gets stuck in the patient, in the person who is shifting, and the tube gets dislodged. A very famous case from Rajasthan, where the patient had a cholecystectomy and was shifted, but unfortunately, while shifting, this thing occurred. Means when you are shifting, the tube gets stuck and the patient is shifted, and the tube came out, and the patient had a leak and ultimately died. The case went on in court for a long time. Tube dislodgement, skin abrasions. In a hurry, the OT boy will try and pull out the OT dress from behind, and the patient gets a skin abrasion. Urethral damage from pulling of the catheter, dislodgement and sprains, etc. There has to be a proper system for patient special conditions where the patient needs to be operated in different positions. Even in supine position, if a patient is lying on the board for a long time and there is a pressure point, the patient can have neuropraxia. And especially when the patient is being turned onto the table or being shifted, we need to take special care with the help of gel pads or cotton or something or the other, so that we do not cause pressure problems. Patient has to be induced on the back and then turned and reversed at the end of the procedure while shifting off the table on or onto the table in different positions. Contributing factors to surgical arrangement: inadequate communication amongst team members and with the patient. We see this every day. We say, please give general anesthesia. Anesthetist says, no, I'll give spinal anesthesia. You communicate, you talk, you tell why you want a general anesthesia, because you might have to go pull the momentum and that might cause problems. And even if you're doing pelvic surgery, sometimes you need to go up. And if you are anticipating that you'll have to go up, then you need general anesthesia or specific. So it is best to communicate with the anesthetist, to make friends with your anesthetist. You can't be having love-hate relation that till the patient is induced, you have a love relationship. And the moment the patient is induced, you have a different type of relationship. So make friends with your anesthetist, communicate properly with the whole team, what surgery is being done, what position you will need, what anesthesia you need. Errors in patient identification, very important. Incomplete review of the patient health records and diagnostic studies. We need, because we are in a busy hospital, if we are in a medical college setting or in a very, very busy hospital and we have parallel theaters running, we need to see to it that we have identification tags on the patient and we need to identify each patient with the name and other parameters. Just name is not good enough. We know of cases where people have been operated because of the same name. In the OPD also, so we say it is a coincidence that same name patient is there. 2-3 same name patients are there. So we need to check with the father's name or husband's name or other parameters that we need to be very careful that we are dealing with the right patient. Traditional hierarchical and autocratic structures are, so we don't call them theaters now. Previously, it was operation theaters. Now these are operating rooms. There, nobody is the hero. The only person who is a hero is the patient. We need to have equal level communication with almost everybody, right? And not the surgeon is not the hero. So there need not be any autocratic attitude in the theater. Autocratic attitude can lead to trouble, like what I said about the plane crash. What are the contributing factors which can lead to errors? Absent or inconsistently applied rules and procedures. Fatigue of the staff, of the surgeon. Time pressures, like people waiting in the OPD, I have to go. I have a next case coming up. I have to do this. I have a meeting there. So, emergency surgeries, cultural differences between patient and staff members, language barriers, staff shortages, and multitasking. This is one of the most important things which leads to errors, where your mind is somewhere else and you are doing something else in this theater. Confusing packages. Now with the so many new equipment coming in, staplers and firing guns and all those things that coming stapling guns, we need to have a proper review of the packaging material. Clear instructions have to be there. Insufficient orientation and training of the staff. So many cartridges have been lost because the staff or the surgeon did not know how to use it, how to fire it, and patient requiring unusual setups or special requirements like different positions, lithotomy Trendelberg position, or a kidney bridge, or a head up, some other situations. So you need to be very careful that you have proper systems set in. Intimidating management styles. So you will not get this, you will not, this will not be available. Suddenly you get in the morning that this tube is not available or this instrument is not available. You have to manage it whatever is available. Blaming culture, you need the sister blames the surgeon blames the assistant blames the staff. Autocratic and dictatorial attitude, lack of team spirit, and inflated egos. These all contribute to errors. What is the impact of ineffective communication in healthcare teams? The Joint Commission has cited communication failure as the number one contributing factor in reporting Sentinel events. The Veterans Administration National Center for Patient Safety has identified communication failures in approximately 75% of more than 7,000 root cause analysis of adverse events and close calls. Closed malpractice claims from various clinical settings showed that ineffective communication and teamwork contributed to medical errors and patient harm in 43% to 70% of the cases. So there is a two-challenge rule. If somebody is making a mistake, what do? It is your responsibility to assertively voice your concern at least 2 times to ensure that it has been heard. The member being challenged must acknowledge, provide supporting information with second challenge. If the outcome is still not accepted, use CUS as concern, uncomfortable, and stop. You can say, sir, I am concerned that we need to do this rather than this. Or you can say, sir, I am uncomfortable. Or say, sir, can we stop? Take a stronger course of action, empower any member of the team to stop the line if he or she senses or discovers an essential safety breach. Because what we are doing is for the patient. We need to have the patient at the foremost in our mind. Analyzing errors and complications. The method, the machinery, the people, and the material. Supposing we are dealing with a car and the car has poor gas mileage. What are the things? And this is a method how we analyze. In the methods, are we driving too fast? Are we always very late? Are we very impatient? Are we using the wrong gears? Or can we not hear properly? The radio is too loud, or we can't hear the engine, or the fuel mix is, from the machinery point of view, the carburetor adjustment is not good, and all those things. Similarly, in people who are maintenance, who are finance, salaries, no awareness, who are training, who are driving habits, material, wrong type of things being used. So you need to analyze whatever you are doing in a proper manner. If you have complications, even without having complications, we need to analyze properly. In the construction industry, only 1 in 50,000 structures partially or entirely collapse. In the aviation industry, odds of being killed on a single airline flight are 1 in 29.4 billion. We need to learn from the aviation industry. There are checkpoints for the pilots. Before takeoff, parking brakes, they have to say set, flight controls, free and correct, in flight instruments set. So everybody just stops and does the checkpoint. And they have to do it religiously and meticulously. We too can have the error reduction strategies in our theaters. We need to provide support for new equipment, and suppliers provide staff education. Whenever you get a new instrument, a stapler, a cautery or something, we need to be trained in it. Use of standardized procedure. Improve information access of patient records. The whole record of the patient has to be on the board so that the surgeon or the assistant can immediately look and say, yes, this is this, this is this. We need to have this surgical safety checklist in the OT. How to reduce the human factors? Reduce reliance on memory. Or remind me to do this. Use checklist, which is the surgical safety checklist, instrument checklist, drug checklist. Have proper protocols, safe site protocol, ICU protocol, and computerized decision aids. If there is a protocol that when you put in a catheter, you hang that catheter to the side of the table. Simple. It is a protocol. It has to be followed. What happens is, if that protocol is not followed, the person who puts in a catheter, the bag is empty. But by the end of 2 hours, that bag gets filled, and it pulls out the whole urethra. Similarly, you can't remind me again what I'm doing here. You need to have everything as a set protocol. And then the most important thing is the WHO surgical safety checklist. Prior to induction of anesthesia, prior to skin incision, and prior to patient leaving the operation theater. Everybody has to do this in a meticulous manner. You have to identify, everybody has to stop and check that the patient is confirmed, the identity, site, procedure, consent, whether the site is marked or not, anesthesia safety check is completed or not, the pulse oximeter is on the patient or not, is there any allergy, difficult airway aspiration risk, or risk of blood loss. Then timeout, confirm all the team members know each other by name. Then everybody confirms the patient, the site, the position, the procedure, and any critical events. Surgeons, what are the critical or unexpected steps, operating blood duration, blood loss, and everything. Anesthesia team reviews, is the patient diabetic? Is she hypertensive? Did she take the thyroid medication in the morning? Nursing staff, do you need cautery, you need harmonic, you need all equipment is there or not, whether antibiotic prophylaxis has been given or not, whether the MRI, CT scans are displayed or not. And then before you close the abdomen, whether what is the name of the procedure that has been done, instrument, sponge, needle count, labeling of the instrument, any equipment causing any problems, and then anything for the recovery point of view. And these can be modified. You can modify these. Like in our department, we have modified. Like before induction of anesthesia, inform chief. Who's the chief? Almighty. Or if you are a junior, you need to inform the chief that you are starting the case. Before the moment the patient comes on the table, you have to talk to him. 2 words of comfort has to be spoken to the patient, because that environment is a very, very scary environment. And confirm that the biopsy has been done, investigations in X-ray and biohazard things have already been checked. Confirm what position of the patient will be there. Everybody should know that the patient is going to be in a prone position. You can't have all those leads, ECG leads on the patient, and then you say, why did you put all the leads on this side? Before closure, you need to say whether you need to put any tubes, Rice tube, chestostomy has to be done, stoma has to be done, biopsy, anything else has to be done. Always make it a habit to say anything else to be done. And then post-operatively, instructions have to be given. What is the position of the patient, whether it needs any splint, whether the patient goes to ICU, and then finally, thank the chief. We really not are the surgeon. The surgeon is somebody else. We are just instruments being used by somebody else for somebody good of the mankind. And we need to be thankful to that chief who has put us in this position. We need to have preoperative checklist. Before the patient comes to the theater, the name is checked, the vital markers are checked, the PSC has been done, fitness has been obtained, biopsy of the patient is there, consents, all consents. And today it is very, very important that you take all sorts of consents, whether it is of stoma, whether it is blood transfusion, whether it is you going to use staplers, what procedure, every consent, change in voice, change in tail rotation, anything. Other departments, supposing we need the cardiothoracic department, whether they have been informed or not, patient has been explained about nothing by mouth, complete preparation of the part, position, everything has been done. Nebulization if required, valve preparation, cross match. And you have to instruct, supposing the patient is for an MRM, you have to give instructions that the patient has a trip on the opposite side, not on the same side. So many times you see in the theater that the patient comes with the drip on the same side, and then you have to cut a sorry figure. And all CT scans, MRI, patient is tagged, and somebody has to come with the patient. You can't make the patient run into the theater and put her or him on the table. And then the post-operative, what is the position? You need supine, you need no pillow, you propped up, monitoring, medications, comorbidities, all the medications that were pre-operatively have been started. Biopsy form has been filled or not. You have to write the clinical history. Orientation is done or not. Chest care, tubes, charting, instructions to the patient, and the staff has to be given, whether it is setting up food. Nothing has to be taken by mouth, or movement restrictions have to be done. Instruction to the nursing staff, and all those things. You need to have proper guidance in the post-operative period. So international patient safety goals are identify the patient correctly, improve effective communication, improve the safety of high alert medications, ensure correct site, correct procedure, correct patient surgery, reduce the risk of healthcare associated infections, and reduce the risk of patient harm resulting from falls. The advantages of the checklist. Checklist can help improve appropriate antibiotic administration preoperatively, prevention of hypothermia, availability of equipment in the operating room, communication safety culture has to be developed, and anesthesia safety. It reduces specimen problems like loss of the specimen, wrong test, inaccuracies in documentation, surgical related complications, and mortality and morbidity. Yes, mortality and morbidity. 47% reduction in mortality and 36% reduction in complications in a cohort of nearly 8,000 patients from 8 countries. 47% reduction in mortality. Can you believe it? Ergonomics, theater ergonomics are very important. Educate employees about potential errors and how to avoid them. Develop near miss reporting mechanism. Anything going wrong needs to be reported. Your generators, whether pests in the OT, looks funny, it's not. Keep the work environment safe. Like I said, wires and sharp instruments, so that your ports, your very precious things don't get lost. Anesthesia factors, pressure from above, kicking patient, awake patient, awareness in GA. You need to talk to your anesthetist about. If you think somebody has been doing too many punctures, then you need to talk to them that this is a patient. Supposing this was a known patient, would you have permitted this thing? Don't forget the specimen, proper labeling, marking, preserving, form filling, handing over, and dispatch, right? Beginning, inform the chief and thank the chief. Environmental safety means adequate light, ventilation, stairs with handrails, window door closers, slip preventing floors, fire extinguishers and fire alarms, prevent noise pollution, heavy and fixed beds, safe wheelchairs and trolleys, no water logging in the bathrooms, call bell system for patients, and adequate number of bed screens to maintain privacy of the patient. And ultimately, be human, care with compassion. Patient, you can imagine if you have ever been to the theater as a patient, you know what it feels like going to the theater. So be human and assistance at all times. Telepresence, teleteaching, telemonitoring, use the technology. You have the recording system. This is what we made. It was a very simple device, a single chip camera, and displayed on the screen, and also being. Remember, someone is watching. Discipline is doing the right thing, even when the policeman is not there. Means doing the right thing even when nobody is watching. Self-review and peer review. The best way to learn is record and review your surgery, review your narrations, practice what you learn and review. This way, you will learn a lot. And we need to introspect. Everyone makes mistakes, but we cannot share them. So many things keep piling up inside us. So many people keep our secrets. If we share, others won't make the same mistakes. If all share, there will be a system improvement and less mistakes will happen. Each event has to be recorded and reviewed. And we talk about learning curve. What learning curve? You had made a complication in your learning curve. There are thousands and thousands of surgeons in the learning curve. And who is paying the price? The patient. We need to do something about it. And finally, patient safety in surgery is being recognized as an important public health problem. Surgeons and their whole surgical team plays key roles in protecting patient from harm, avoiding and reducing errors, and promoting safe operative practices. But also remember, protect yourself too. Litigation are coming, is going to come. And so the request, the prayer that you will make to God would be, God, please make me a safe surgeon. Thank you very much. I really thank Dr. Kapoor for giving this opportunity to interact with all of you. Thank you. Thank you very much.
So that was a presentation by Dr. Rajgovind Sharma on safety in surgery. Actually, when I asked him to make a presentation, I specifically requested him that instead of a surgical or an oncology related topic, if we could talk on a general philosophical topic. And I think these issues are also very important, and we will have some more similar presentations on soft skills in future sessions of Jaipur Surgical School also. Since we have a couple of minutes, a few points I would like to kind of reiterate just to highlight the importance. Two words which he used, an incident and an accident. Incident is something which was not supposed to happen but happened, but it did not cause any harm. Some examples could be that a wrong patient was about to be wheeled into theater, but somebody detected it, or a wrong injection was about to be given, or say a dose of antibiotic was missed, although patient recovered well, but something which should not have happened. Similarly, in an operation where you placed a drain, which you thought that you would keep it for a few days, on second or third day, accidentally it came out. Nothing happened to the patient, but it is an incident. It is not an accident, it is an incident. Anything which results in a harm obviously becomes then an accident. So ideally, even an incident, something which should not have happened but happened, should be recorded, should be reported. Second is the issue of environmental safety. I think we all have read that very recently in a very prestigious tertiary level institution, there was a big fire in the OT complex. And unfortunately, one child who was being operated in one of the theaters suffered serious burn injuries and died as a result of fire. Obviously, of course, the fire resulted in loss of crores of rupees in terms of equipment in the theater, but the loss of life was irreplaceable. So these things can happen in very prestigious, very well-equipped, very well-staffed hospitals also. Injuries to patients because of wrong positioning during surgery, foot drop, wrist drop, nerve injuries, vascular injuries. In fact, in another very prestigious institution, a very precious patient had severe ischemia of the limb because there was constant pressure by one of the side handles, the metal handles which hold the self-retaining retractor. There was pressure on the arm which was undetected, and there was severe ischemic injury. Wrong patients undergoing procedures or even operations happens because of various reasons, similar sounding names, two patients having same disease. So it is not very infrequent that we say send the gallbladder cancer patient to radiology for PTBD. Now, there are two gallbladder patients, cancer patients, and the nurse by mistake sends the other patient to radiology. And if nobody checks which patient has come, intervention can be done on a wrong patient. Frequent change of beds of patients, because we always say send bed number 14 for upper GI endoscopy. And this again has happened in a very prestigious institution. This instruction was given by the resident to the nurse. She could not implement it immediately. After some time, she sent the patient, but in the meantime, the patient's beds had been changed. So there was another patient on the same bed, but on which the endoscopy was not to be done. It was done. Again, nothing untoward happened, but it was an incident. Sponge count is a very, very important issue because it immediately draws public's attention. And operations where this is more likely to happen, although it can happen in any operation, are long operations, operations involving multiple teams, for example, surgery, gynecology, CVTS, different teams coming in and doing different parts of procedure, or the same department, but there is a change of team. So one team does the resection, other team does the reconstruction, change of nurses, which happens very frequently because they work according to shifts. So these are operations where extra care should be taken because these are more likely to have a sponge or instrument count problem. And the last issue is that what to do if an incident or accident has happened, whether to hide it, conceal it, or whether to reveal it. In most cases, it is better to reveal it because the more you try to hide, from some other source, the patient or the relatives will come to know about it, and then they will lose the confidence in you. So most people recommend that if something has happened, it is always better to be honest, be open, be truthful, and explain it to the patient and relatives if there are any possible reasons for it. And of course, documentation is very important because if an incident or accident happens, it may result in a medico-legal case. If you document the events properly, then that is the best way to save yourself, even if a case is filed against you. So students and surgeons who are attending this session or who will be watching this video, if you want to read more about complications in surgery, please send me a mail, bkkapoor.india@gmail.com. Write complications in the subject of the mail, and I will send you some general chapters from my online book, Pearls in Operative Surgery. And also, I wish to inform that this year's Jaipur Surgical Festival, which is from 6 to 8 December, at Jaipur, is on the theme of complications in surgery. You can go to the Jaipur Surgical Festival website and see all the details. Piyush, you want to add anything? So I think we will close this session. I'd like to thank Dr. Johnson who has joined. Dr. Johnson, you are from which country? Okay, I think we can and then
Not responding.
yeah.